Hello, everyone. We just give 1 minute or a few seconds for will be more people to join us. Okay, so we know the history for when Louise Brown birthed in 1978. That was a big achievement in human IVF science, right? And we're going to talk today about a few things and something that you might also know and you practice every day. But before we start, I will remind you to, if you have any question or any comment, you can use the chat window. And if you would like to speak, you can raise the hand, use the hand to unmute, or somebody will unmute you from the control, the Zoom control. And you can share your experience or share your opinion. But I just want to remind you that this webinar will be recorded. So if you don't mind to be recorded, that's okay. Right. Okay. So we will start the second session, and thank you for joining. As I said, there is a history for human IVF, and that was like 4 decades, I think, and that was because when Louise Brown born, that was a huge effort, like hard work from Sir Robert Edward and Dr. Steptoe. It's like more than 10 years from the hard work. And since that time, we see how is the IVF growing and rapidly developing. So a lot of events followed, like in 1983, the first baby born from frozen embryos, and then there's ICSI, and the list is actually long. So they established the first IVF clinic. It's Born Hall Clinic, and that is in 1980. In 1980. So we can imagine how was the lab there at that time with basic equipment, and the data available was limited. But yet they achieved more success. So in 1918, the same year, it's reported from 65 patients with natural cycle. They've been able to retrieve 45 oocytes by laparoscopy from 44 patients. And they achieved 4 pregnancies with 3 deliveries. But we can see today how is the advances in our technique and all the development. We are reporting our data in a different way. So today we'll talk about important data in our lab and how we use it. But I'm not going to talk in more details, as a lot of laboratories, they exactly know how they use this. But it's just a review with everyone, and if everyone would like to share, what is your opinion in that? So the first important data is the KPI, the key performance indicators. And these indicators is a set of data that measure how well something or someone performing. So it evaluates the efficiency for individuals, equipment, and programs. So every lab should put their indicators, and they should consider the indicators that related to the laboratory, but also they have to consider other indicators that it has indirect impact on laboratory performance, like clinical data, communication, and the safety measures. These data sometimes, or this areas, sometimes they have errors, and there is a risk of errors around the performance. So when you set your indicators, you need to compare the value or to put reference for these values. So you have to also, there's another two values need to be checked with the indicators. There is a benchmark and the cutoff value. So that is exactly how you can measure the performance. So we have the benchmark, and the benchmark is a criterion for a quality, and that is usually expressed in a measurable standard. And it means that you, very simply, you have to set a target. So when you set the target, it should help and to measure exactly the position of the practice in comparison to other entities. And the other entities could be national or international practices. So when you set this value, it means that you benchmarking. So you need to put your target, the value target that you need to achieve. And the sources for this benchmarking might be from internal sources or external source. The internal sources is usually is the traditional ones that we use in the lab. So everyone using the same indicators. But when you put the benchmark for every indicator, you should, there is a way to calculate it to see the mean, and then there's another two standards to calculate it. So the benchmarks, usually it set the goal that where you need to achieve. And these, like normal, what we use every day, like the fertilization rate, the embryo cleavage rate, blastocyst formation rate, and also the pregnancy rate. So the external source for that, it's usually we look for the local practices, where's the best practice that we compare ourselves to. And there is also the local regulatory bodies and the professional groups, or national or international societies. So those are the sources that you can get your benchmarks, and these are useful for if you would like to see the position of the practice in comparison to other entities, as I said. But also it's for if you see the birth rate or the multiple pregnancy rate, so that is a source good for comparison. So the other value that the indicators need is the threshold or the cutoff. So the cutoff value, it's a critical value that is it shows the quality of the laboratory performance, and it's a critical that it gives you a warning whether the performance within the acceptable range or not. And every laboratory, they should set this value carefully, and it could be in a negative or positive form. But also, it's not an absolute value. It needs to be constantly reviewed, because it can be changed by time. Depends on how is the achievement and the performance of the lab. So the threshold value also need to be appropriate set, because if it is too low or too high, that is not helping, because you need to set the proper or the appropriate value that will help to detect the defect of the performance and whether we need to apply a corrective action. So this is the KPI and benchmarks and the thresholds. So when we come to use this data, we learn a lot from this data, but also we can share and communicate this data with each other. And because we have different practice and it's variable between laboratories and regions, we always need to explain our method, protocol, definitions, and sometimes also the calculation form. And that is apparently that we don't talk about the same thing, or sometimes so we don't speak the same language. That's why we need to explain it every time we need to share this data. And because we don't speak the same language, or there is a no language all over the world, there was some meetings like consensus meetings trying to make an agreement, and these agreements is for definitions, terminology, calculations, and benchmarks. So they try to put a common language for to communicate and report the data between the practices. So the first one we will mention today is Istanbul Consensus, and that was in 2011, and that mainly for standardized definitions and establish the minimum criteria that is needed to describe morphology and grading from oocyte to blastocyst stage. So they discussed every stage, and because the embryo development is related to time, so it was important to set and agree on the time that for assessment and observation for every stage. So that is, they actually discuss a lot of things in this meetings, but it's all related to the morphology. So the second meeting was the Alpha Consensus meetings, and that was focusing on cryopreservation. So they discussed 14 performance indicators, and it was discussing mainly the indicators all related to cryopreservation to set the cutoff and the benchmarks and the competency of the practice. So from the 14 performance indicators, that should cover all the stages for cryopreservation, again, from oocytes, zygotes, cleavage stage, and blastocyst. And so they discussed the benchmarks and for like survival rate and the embryo potential development after oocyte warming. So they put the benchmarks for many stages and for the cryopreservation, but also some of the benchmarks like clinical pregnancy and implantation rate that should be set in reference to the fresh indicators. So in 2012, that was the Alpha Consensus, and there was no consensus that time for the fresh indicators or the usual indicators of the IVF lab. But 5 years later, in 2017, Vienna Consensus, they discussed a lot of indicators, and almost most of the indicators that is related to the all IVF processes. So they focused on the minimum KPI required for any practice, and identify the essential indicator for every process. And they said also they try to agree and set values for measuring the competency, as well as they set an aspirational benchmarks. But also they agreed that there is a lot of confounders that they need to consider. So there is many consensus, and we see how is the effort to create a common ground to talk and to communicate with each other. But there was some processes that it's difficult to put some values for these processes, like sperm recovery and postal motility, the cutoff motility and count for IVF or ICSI procedure. So these also was, that was arguable, still not easy to put certain value. And also the embryo selecting for cryopreservation, and that is one of the things that is a variable practice. So if we would like to improve, that is the only way, that we need to keep documenting and collecting data, and always we have to go back and check our data This is the only way that we help ourselves to improve. So, but we also need to consider the some external factors that is always impacting the indicators, but there is other many factors that always can be kept in control to optimize the performance. So it's important for every lab to determine their indicators, their own indicators, and this should be always relative to the process and the treatment that they provide. And of course, the KPI and the benchmarks is very important and necessary for the quality improvement program. So the benchmarks also allow us to understand what can be achieved when we compare ourselves to other entities, whether it's national or international. But although there is a lot of KPIs that is the traditional ones that is everyone using, but we have to be always creative and be ready to put a new ones when it's necessary to be used. So at the end, I just wanted to say that for years and years, we try to create a common language to communicate our data, but yet the agreement was only for a certain level. And that will lead us to a question whether if we use the artificial intelligence and the automation in IVF, that might help us to create new language for communication. And that was all for today. Thank you. Okay, good that I didn't leave. There is a question, how can we set our own KPI? So the KPI should mean something. You need to evaluate something, and you need to go through every process and see what is your outcome that you're looking from this process. Like for ICSI, what you are looking for too, you need to get a lot of fertilized eggs after your ICSI procedure. So you measure the ICSI technique by the number or the percentage of fertilization rate that you get. So you set your fertilization rate, and that is going to reflect the performance or the competency of the operator. So this is how we put the indicators. It's like also there is indicators for incidences and risk that can happen. So you put how many through the year you had to report incidences, and how is the miscommunication happening. So that is another area in like a lot of people, they know that there is IVF fertilization rate, and this is a fertilization rate failure. So a lot of things that we can look for, but it's important also to include other parameters that it's reflect how is the harmony between different department in the practice going. That is very important as well. So there's a question how to use the KPI in a small lab. So in every lab, there is always some data that you can collect, but in a small lab, you need to collect a good number of data. Like if somebody would like to make a new trial for anything, they need a certain number. So this certain number can be collected in less than a month in a lab that perform like more than 1,000 or 2,000 cycles per year. But for a small lab, it takes time, and that is more difficult to control because the translation of what happening between the applying something and you read it through the indicators, that it will take time. So that it needs more better control. So in a small lab, you can still put the same indicators, but the difference is when you get the result or when you see the indicators and you need to go through it and analyze it, it takes time to collect the data in a smaller lab than bigger lab. There is a question of if there was a sudden drop of success rate in a lab, but poor quality embryos become blastocysts, even the air quality and incubators function properly, but few drops were 2PN arrest in ICSI, but not in IVF, right? But I think that is a two question, not one, um, for the person asked this question. Well, the drop of the results in any indicator, it means that there is always many factors affecting the indicator. It's not only one. And as we said, there is indirect and direct factors. So it's easy to control the direct factors than the other factors. So you can't control the clinical stimulation. They can't control the patient group or age or infertility reasons. But what you can control is the process in the lab. So when you have something that is not going correct between, let's say, the ICSI and IVF, and you see a lot of embryos got arrest, I would check at this point the temperature and the air. Even though I still think that it's going well, I need to go through the basics that you have to go just to check everything by yourself. So if you check the air quality, that's okay, but that is affecting the development. But the temperature will affect sometimes the fertilization or the development. So if you get a lot of arrest, you may need to check the temperature, and you need to see where is the position of the dishes in the incubator, whether your incubator is open a lot, because maybe IVF dishes in a different incubator, and this incubator you might keep opening that incubator, so the frequent opening is actually affecting the culture conditions. So you go through like a few factors, but it's not about how we projected. It's better to go through all the factors, even though I think that it might be this factor that is affecting. It's better to go through all factors, because there is a few things might happening and we are not aware of in the lab. Another question, that what is your opinion regarding the KPI with time lapse? Right, time lapse is a great machine, and you can collect a lot of information from that one. I think it's if a laboratory they can use it, they can use it, of course, but the difference is not every lab they can have this information. That is why we have a difficulty in communicating, because we sometimes talk about data that is not available in other laboratories, and that is not at this point, it's not possible to apply this indicator in those laboratories that they don't have the same possibility to have these indicators. But I consider time lapse is one of the an expensive tool in the lab, and if you get as much as information from this from this machine, that would be great. But yet the morphology assessment and all about the whether we have to only use the non-invasive one, that is the debate between whether we need only the morphology or we have to assess other things like the metabolomics or PGT. So that is that's still debatable. So there is another comment for so M2 oocytes, Vienna consensus, which number we should consider to calculate fertilization rate after denudation, before ICSI or after ICSI? Oh, for M2, the maturation rate, well, that is before ICSI, because after ICSI, it should be the same number of eggs injected. It should be the same. Oh, they need to exclude the oocytes that with cytoplasmic abnormalities. Well, no, I think abnormal oocytes should be included, whether they are mature or not. But the morphology of the oocytes, that is reflecting how is the stimulation and the group of patients. That is something that is not controllable in the lab. But maybe you will ask this in a different way, whether we need to consider these in the fertilization rate or not, because these might not be fertilized, or even they fertilized, they develop to a very bad morphology embryos. So this is, I would think whether we include this kind of oocytes to fertilization rate and embryo development, but I think they need to be included in the maturation rate of the oocytes. So another comment, the oocytes with first polar body, but with vacuoles, we include as M2. Yeah, we include this as a M2 because it was mature and it's been retrieved. So it's all counted. But again, this kind of oocytes, it came mature, but it could be bad morphology because of the patient. There is other factors affecting the oocyte growth, or it could be from the stimulation itself. So these factors is, again, it's external factors, but the egg came to the lab and you found it mature, regardless of the quality of the egg, but you have to consider it mature. So if the gynecologist aspirate and it give you like exactly the expected number of follicles, and you collected, let's say 10 oocytes, and then you found like 9 mature, regardless of the morphology, they are 9 mature eggs. But to discuss the morphology, that is a different issue. So for oocyte cryopreservation, if we vitrify the oocytes early, like after 2 hours of retrieval, well, if have any adverse effect while thawing degeneration, right. Okay, I'm sorry, I'll repeat that question again. For oocyte cryopreservation, if we vitrify the oocytes early, like after 2 hours of retrieval, yeah, we need to vitrify the oocytes as early as we can. So 2 hours is a reasonable time. But the other part of the question or comment, will have any adverse effect while thawing the degeneration? Well, if you freeze the oocytes as early as possible, like 2 hours, this will not affect the thawing technique because or the results, because you need to leave the oocyte to rest time enough to recover and the spindle to recover. So when you freeze it early, you give yourself enough time to leave the oocyte to recover after warming. So that is not supposed to affect your results. There is another, I'm not sure this is a question or a comment. So in your setup, what will be the list of the KPI? Oh, again, I think it's every process in the lab needs to have a measure. So there is a say, if you can't measure it, you can't control it. So if there is no measure for something, then you don't know how well it is or how bad it is. So you need to measure it. Everything needs to be measured. You know what? In your reception, and you have a clinic, in your clinic, there is a reception. The receptions pick up the phone and answer. If they miss the phone, that should be measurable. It means that they lost the patient. The patient could, in a situation that needs an urgent help. So everything needs to be measured. So but some indicators, they are more important than others. But everything needs to be tested, everything to be measured. Like the time that you start the egg collection, that is also can be tested, that can be measured. Like, are we inconsistent performance, or we just sometimes miss, the gynecologists get late, something happened like an emergency. So if we are in a consistency, then it means that we are okay. So you can measure it and then you can take it from there to improve. But if you can't measure it, then you don't know. your situation. Right. So that is most of the questions. I don't think there is more questions. Right. Right. So thank you very much for attending. And please, if you have any suggestion and if you would like to discuss any other topic, please you send your um, comment to the email that is provided, and we will happy to talk about next time. And hopefully you can communicate with us more. So maybe next time you can speak with us and tell us what you think and what you do exactly in the lab, because in this era we have in this time and with the circumstances happening, we have a lot of time to look at our KPI and look at our data. So that is a good opportunity to share and to look for what is new we can improve in the lab. Thank you very much.